Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm talking to Patrick Denston, a PCN Digital Transformation and Change Manager and a Practice Business Manager based in Farnborough, Hampshire. He's also an NHS England AI peer ambassador. Patrick has a proven track record of successfully introducing new technology into general practice. And in this conversation, he explains how his practice has moved away from manual paper-based processes to embrace digital and AI tools and advanced data analytics. We discuss how these tools are helping to improve access and address other challenges in the practice. And Patrick also shares some very practical advice for other practices looking to embrace new tech, including how to navigate the busy market of tech suppliers. And we look ahead to the future of general practice, discussing the government's 10-year plan and how AI and data-led population health management could fundamentally change the way practices operate over the next 5 years. If you're listening to this podcast, you know just how fast general practice is moving. To keep up, you need more than just headlines. A GP Online subscription gives you expert analysis on the latest news affecting general practice and how it impacts on you. A subscription to GP Online also gives you access to MIMS for prescribing information and MIMS Learning to help you complete your CPD. It's your daily briefing and your education platform in one. Subscribe now at GPonline.com. I'm delighted to welcome onto the podcast now Patrick Denston, who's a PCN Digital Transformation and Change Manager and Practice Business Manager in Farnborough, Hampshire. Patrick has a really strong record of introducing new technology into general practice, and that's what he's here to talk about today. Thanks for coming on the podcast, Patrick.
Thank you very much. It's a real pleasure to be here.
So I mentioned there, you're a digital transformation and change manager as well as a practice business manager. What does that digital transformation role involve, and how did you get involved in that?
The role itself is constantly evolving as primary care and the NHS becomes much more digitally relevant and much more sort of fit for the future. And I think it's on everybody's agenda and everybody's radar to do things. It started for me 5 years ago. It was actually just bringing in modern standards and a little bit of automation and using even simple things like emails much more effectively rather than fax machines. And now it's evolved into much more of introducing new tech, using data analytics to shape the future and actually not just having a go with things, but actually strategically planning why you might need some digital tech or where digital would be most appropriate in what it is that you're doing.
And how did you end up in practice management? What was your role before you moved into general practice?
So I used to work in the leisure industry. So I used to manage swim programs for various leisure centres, and then after that, leisure centres across the south and various places in the country. And it got to a point I was interested in a new challenge, and a role for an operations manager came up, which at the time I think was quite new in general practice to start having operations and business managers. And that was just before the pandemic. Because I thought leisure is not the most techy of industries, but actually it was miles ahead of even quite successful general practice when it came to utilising digital tools and computers and things to get things done and telephony. And some of those things are now normal for us in general practice, but there was so many transferable skills from other industries that you could use within general practice to make improvements.
Obviously, there was a real sea change in tech during the pandemic, kind of like general practice had to really sort of get to grips with things like online consultation systems, but they were rapidly being rolled out. In your experience, how well do you think general practice is getting on embedding all these new technologies?
So I think in the space, we're just coming up to sort of 6 years since the start of the pandemic and 6 years where I've been in general practice. And if I sort of describe the first maybe 3 months of while I was there was somebody employed to print off emails, to scan them into patient notes. I was thinking, but surely you can see your phone stats, you can see what's coming in, going out, it's all digital now. Oh no, it doesn't quite work like that. To me, there was off-the-shelf products that VoIP telephony that you could just buy in quite reasonably, and some of those suppliers saw that there was a big gap in general practice. And I was thinking, well, we do this with other areas, we can adapt it for general practice and we can improve it, and then it becomes obviously contractual, but we can't imagine life now without VoIP telephony, without the ability to call from anywhere. With efficiencies and digital tools and searches and text messaging was a great communication thing. So I spent the first 2 years saying that there's not a demand problem in general practice, there's a communication problem. And nobody really knew what the demand was. Nobody really knew what it is they needed. And COVID actually allowed everybody to stop for a moment and go, well, yeah, we don't know. There's a lot of information we don't have. A lot of information that other industries would rely on for forecasting, for staffing. And that was very much evidently missing. So there was some quite easy wins to start off with. Now it's much more that we are data focused and we're getting that information in That's been the biggest change, is actually having the data presented in a meaningful way. And that's continually evolving with Power Platforms and AI at the moment. That's the most exciting bit.
Obviously, there's been a huge focus on how new technology can help address the challenge of access. Everyone now has online consultation systems, but what other tools have you implemented in your practice, and how has it changed the experience that patients and clinicians have?
One of the other areas, and this was something that I noticed coming in, not knowing about the NHS and general practice, was you assume that it's all interlinked and interoperable, and there was a difference between secondary care and primary care. I mean, I was that naive when I first came in, and I was like, but it's just the NHS. An ambulance should be able to see a medical record. And they were like, no, you can't do that. And all of those sort of complexities, I think, they're complex problems that we need to try and sort of address and fix. And with the practices that we have, I think there's a great area of tech companies that are trying to implement things. And the things that have worked well for us, it's not just the VoIP telephony, because actually VoIP telephony is like saying I've got a mobile phone. There's a big difference between an Apple and an Android and an old Nokia that we'd had 10 years ago. They're all mobile phones, but they all do very different things. And so for us, it's been bringing in things like digital care navigation. So using telephony systems so that you can map the flow so patients can find information in hours, out of hours. They can be directed to appropriate care that's relevant to them without actually thinking, well, what do I do at this time of day? Who should I be talking to? Where can I get this information? And a lot of people jump to Google, but still there's a huge proportion of patients and the population that pick up the phone. Their GP, a lot of the time, they know them on first name terms. They'll know the receptionist on first name terms. They know the telephone numbers legit. They're not sort of using a search bar and potentially getting the wrong information. So we've got a lot of detail in our phone system with options, allowing them to check appointment times, it'll send them information about the NHS app. We've done a big drive on the NHS app for patients requesting things, looking at their own bloods, knowing their own numbers. And that's made a big difference to access. Currently piloting an AI assistant for the telephony. So it'll ask the same questions as the online access would. It basically gives it equitable access. So patients can ring when we're not even open and give the information so that when we are open, they can be directed to the most appropriate care in a very timely fashion, not actually while somebody's panicking on the phone when they know they've got big call numbers coming in. And for us, it's reduced call wait times. Our wait times are very low. Our volumes are very low. Patient satisfaction goes up with that. But it's not just adopting the technology, it's also utilizing it and tweaking it and changing it as you go on. We do use other sort of AI forms. We've got digital scribes, trial quite a few of them. There are some excellent ones out there from various providers. But again, that interoperability is very important, making sure that it goes into the clinical record, making sure it has the medical licensing to know that it's safe for patients, and flexible working. Everybody in our team now has their own laptop. They can work from any desk, any hot desk. Every desk has 2 screens that allows for sort of much more conjoined working. And they're in the most appropriate room for the role that they're doing that day, which then utilizes estates by harnessing digital to do that. Automating recalls, making sure that we don't just try 3 invites and then excluding people. We just keep inviting. We try and use the automation and risk stratification to invite the most needy patients in first, but through clinical need rather than anything else, rather than ease of let's just get appointments. That's only possible with digital.
You said you've got like quite low wait times and things like that on the call system. I mean, how have you achieved that? Is that just through having the digital phone systems, or is it because of this new digital assistant?
So we had low wait times before the digital assistant. So for us, the digital assistant was about equitable access rather than making it more efficient. The first bit was getting the digital phone system in so that you could see where your peak demands were. Like obviously we know first thing in the morning is quite demanding, but also first thing in the afternoon was. It was then making sure the staffing levels reflected that. They could have other things to do, and then trying to reduce call volumes. So looking at the reasons why people were calling in. So if they're calling in to check an appointment time or cancel an appointment, if you can do that digitally, which we do through our telephony system and the NHS app, that reduced calls. People were calling in to book a blood test, but we made them all available online. To book a cervical smear test, those are all available online. So you can just book directly in if you know you've got that. Similarly, when we want to recall patients in, we're sending them booking links. We're making it as easy as possible for patients to book the appointment they need and the care that they need without actually having to call up. Proactively calling out to those that haven't got text messages, NHS app, in the quieter periods, because you can map where the quieter periods are, or having different work streams, because you know that there are certain times where there are less calls coming in. So you can be working on something proactively rather than sitting there waiting for a call to come in. Prioritizing different tasks throughout the day. So we know that everybody answers the phone first thing in the morning, but that then drops off as the day goes on, and making sure it's equitable throughout the week. So we don't have a particularly tough Thursday and a particularly tough Monday, making sure that it's leveled. And it changed our rota levels, our staffing levels, but it wasn't just a case of more bums on seats. It was, how do we lower the demand and also increase the resource?
What advice would you give to other practices that have been embracing new technology? Is it easy to set these things up, or does it take quite a lot of time and training to change the way the practice works?
It's listening to what people want. Nobody really likes to be changed, and everybody will adopt different things at different speeds. So there's very few things that we've implemented that have then become mandated. Even simple things like headsets and handsets. Some of our GPs will still dial a number on a telephone, and we've had VoIP telephony now for 4 years. But when they're ready to use a headset, that's great, brilliant. And sometimes it might be forced because they might end up in a room where the handset doesn't exist anymore. Similarly with like scribes, some people are very comfortable with using them. Other people quite like to type. Again, you just sort of give them the time, let them come around to it. That comes an idea. Some people never want to work from home. Other people, it's useful to them on occasion if they're having their boiler fixed, for example. It's much easier to be able to work remotely, whether that's a receptionist, pharmacist, a administrator, secretary, or even a GP. And sometimes that's enough of an incentive to let them build on that. But the advice would be is listen to the people you're working with, but also make sure you're not implementing something digital just for the sake of it. A lot of companies and people generally will say, I've got a digital solution. It's like, there are no solutions. There are digital tools. And a tool is only good for the problem that you're trying to fix, amend, or change. Otherwise, you'll end up with a shiny digital product over a broken process. It's remembering to be patient, not be excited by tech and what it can do. And if somebody's trying to promise you the world from a sales perspective, chances are it's not that good. So do your due diligence and talk to other people. I think the other thing is at the moment is ask questions. Don't be afraid to ask when these suppliers come to you and sort of say, this is what I've got. And ask why, and ask what it is that they're trying to fix or what they're assuming you have a problem that needs fixing. Because sometimes it doesn't. Sometimes it might just be a change of process, but there'll be no benefit from it. A lot of these digital tools and new digital tools are in development. You've also got to give the time to feedback what's working, what's not working. Why do you like it? Why don't you like it? What works for you? Don't be afraid to ask for trials to meet other places that are using it. Who's going to endorse their product? Who's going to talk honestly, and find those people that you trust to talk about different products, because there are so many out there.
I mean, I suppose if you're involved relatively early on in a product's rollout in the NHS and you're giving them feedback, do you find that they will tweak things quite a lot and tailor things to the things that you need?
Yes and no, depending on whether they can tweak. Just because it seems simple to the user might not necessarily be simple to the coder, or it might then sort of exit the lines of what their medical license is to do and things like that. So certain things seem easy on paper, might not be that easy. So don't write a company off if they say we can't change that. I think the companies that have been most successful and the ones I've enjoyed working with over the last few years are the ones that have got very public roadmaps. So you can actually see what they're working on. They've got it on their websites and they're open about it, and they're open to that feedback. Some are reactive. We've seen some great successes in reactive companies within primary care that really do listen, and they really want to know how to help, how to improve, how to get the next bit of product out there.
You were kind of touching a little bit there on processes and stuff. I mean, how important is it to make sure your processes are right before you introduce new technology? Do you need to be really clear about what you want the new technology to do before it is rolled out across the practice?
I think for some of the more complex or the more advanced products, I think this is where it's slightly unique in primary care compared to other areas. So you've got your clinicians that have studied for years, decades, and then specialized in things where they fully understand their part of the problem. And I could sit here for the next 15 years and I still won't know what they know. And then you've also got the other area where you've got receptionist administrators, and that's a job role that the clinicians have also never done or never experienced. And so I think when you're trying to fully understand a process, you need to be very strict that it can't be process change from just one end. You have to have the right people in the room, really talk about what the current process is, what's working for some and not for others, because otherwise you won't be able to change either end of the process. And the only person that will get the failing will be the patients. When you fully understand what the current process is, then you can layer digital over the top. And you can look at whether that digital tool fits your process or whether you need to change the process that you currently have to fit the digital tool, because everybody's processes, especially in primary care, are very different. And that can be affected by staffing levels, estates, skill mix, finances, experience. So you've got to make sure that it is the right product that fits, or whether it's worth investing the time in changing your processes and upskilling your teams to actually use the product that's coming in.
You've also mentioned that you've got really high uptake of the NHS app in your practice. How have you achieved that? Has that made a difference to you, having that high uptake as well?
Yeah, very big difference. So the first bit for me was I really wanted to be honest with the patients as to why we were pushing the NHS app. The first cohort that we really targeted were patients with repeat medications. And I was very honest in the initial communication. I messaged all of them and said, if you use the NHS app for ordering repeat medications, it saves the NHS money. You can track where your request is, whether it's been processed. It goes directly to a prescribing clinician, so it's less likely to have errors by going through a receptionist. We'd really appreciate it if you started using it. That was probably the biggest change because people were like, oh, okay, I get that now. That makes a lot of sense. It was always telling the patient why it would benefit them rather than us, because I think the app has also been developing over time. It's significantly better than it was 5 years ago. It's an app that's in a very difficult position that's trying to be suitable for everybody, which no other app on the planet has to be suitable for everybody. So it's really trying to do an impossible task, but it's doing it quite well. But for us, the big difference is there is less mistakes and queries about prescriptions, less calls for booking routine or simple appointments, whether it's blood tests, cervical smears, flu jabs, B12s, even NHS health checks. So we try and make it as accessible as possible. We have GP appointments on there, routine ones. So if you're not in a hurry for your GP appointment, you can book it via the app. And we release those ahead of time so people can actually plan their lives, because we've got to be mindful that we're open often during working hours. A lot of the population work. So if they can just do it quickly from their smartphone at a time that's convenient to them, which is usually evenings and weekends, even booking the appointment can be hard work.
One of the big changes that's happened recently is this move towards online consultation systems having to be open throughout core hours. You obviously were already using a lot of tech. Were you already working in that way, or have you had to change how you work to accommodate that? And, have you seen any increase in demand because of that change?
We have had an increase in demand, but that's only, I think, because of patient awareness.
Yeah.
We've had it on 24 hours a day for 3 years, I think. 2.5, 3 years, long before it was contractual. And we did a little experiment to see whether, if we turned it off, what happened to the telephony compared to leaving it on. So basically, if you turn off your online consultations, your telephone calls go up. It's quite simple cause and effect. And so we figured, well, we'd rather leave it on and be convenient for patients so they can give us the information. And what we've found is that you get a lot of useful information before the surgery opens, so you can actually more appropriately stack up your day and utilize your clinicians more efficiently during the day because you know what's coming in. And that's similarly what we're using the AI assistant for with telephony, that gives us that information. The patient has entered the information in their own words, so you've not prompted, you've not tried to sort of ask posed questions. They've had time to think about it. They're not stressed. They're not worrying that they've been waiting on the phone. They can give as much or as little information as they see as necessary. Has then made a great difference throughout the day, that often they become easier wins because they're patients that are busy. So they like a quick communication. They can be a text message back, or a two-way conversation via text message, or a quick phone call, and with the right person. There is the fear that actually, if you've got a service, a way of opening up access that's, uncapped, that you could suddenly have, 1,000 within a minute come in. I don't think that's ever really been the case. But we do have to increase our capacity on after bank holidays or on a Monday, because we know that there will be an increase in demand. But we've also followed that over time. So that the on the day demand is fairly predictable. What tends to change more is actually the capacity on the day within practices changes more than the demand. But I understand why people were fearful of the contract changes. Because we did it so early on, we did it in a gentle way. It wasn't that it was all over the media. We experimented. We turned up. We didn't advertise and say, our online access is on 24 hours a day. Help yourself. We did have one telephony outage, which wasn't the telephony company's fault. We had a full power outage, and we texted all the patients then and said, online access is there. Feel free to use it. And we had a slight spike, but nothing major.
So you don't have any concerns about sort of urgent queries coming through and that? You haven't had any experience of that? People know how to use it and understand what they can use it for?
All the online access systems have disclaimers in there saying you're not having chest pains, you're not bleeding heavily. Inevitably, no system is perfect, and nobody wants to be in that position where something that potentially would have been preventable happens. We've also got to be mindful that the population know themselves, they know their own health, they know what they need and want. And ultimately, we're not an emergency service. A&E is still there. It is still our safety net. I think the risk of not using it actually puts potential harm on the other 95% that will use it appropriately. And I think that's really important. The risk of inaction should be the ROI that we look at rather than what's the return on investment, and should we not do something because it's not suitable for everybody. Because if we do that, we'll never have capacity for everybody. These tools allow us to have capacity for those that can't use the tools. The other thing is that there's not a set standard as to what an online access form should have or tool should have. And there are some incredibly complex ones that are doing some wonderful things. And there are some very basic ones, but do the right thing. And that's where it's really important that you get the right thing for your patient. Because actually, if you lose confidence in something, like patients did with the first adoptions of, say, eConsult, which was just a really long form that asked you a lot of questions, that confidence now has shifted back. People are using it a lot more again. They know that it does work. It's not a tool for everybody, but if it works for 10, 15, 20% of the population, it makes their life easier. Great, because then the other 80% can use the telephone.
How do you see tech changing general practice more widely over the next 5 years?
I think for population health, it's really critical. And I think as digital and data is becoming more paramount and really in the forefront of everyone's minds, it's also looking for the information you don't have. And what I mean by that is during the pandemic, we realized that actually the BAME population would have worse outcomes if they contracted COVID. But yeah, actually, I think it was about 90% of the population didn't have ethnicity coded in their medical record. Now, there's a similar sort of thing of, well, actually, if somebody hasn't accessed the GP service for years, or they only come in with acute matters like tonsillitis or really basic things where you're not then taking height, weight, BP, bloods, cholesterols, you don't actually know what their baseline data is. And we've started seeing it now with blood pressures, where there is a big drive on getting the population's blood pressures and then managing and controlling and trying to find hypertension early. We know the benefits. They're well established. We're going to have to start doing it with other areas of saying, well, actually, for argument's sake, in Farnborough, why would my practice's prevalence of diabetes be so different to a practice down the road? Because the populations shouldn't really be that different. And it probably means that the question hasn't been asked, have you had an HbA1c done recently? So it's looking for gaps in data. So you can actually start to know your population and think, well, actually, I can now future-proof and plan the teams that I need. And I can start looking at where I need that demand throughout the year. So I can start planning my long-term condition reviews. I can start looking at where things might happen. And that will then also have the knock-on effect of changing you on the day, because somebody's not going to come in with an acute problem that really should have just been a normal problem, long-term condition that could be identified a while ago. That's going to be a big change. The other bit is all the risk stratification. So in Frimley, we've got the Johns Hopkins score. It's fairly well established. We've had it 4 years. It's a very useful, almost currency that's uniformed across the whole system. So it's not just primary care. The ambulance service have got it embedded. The hospitals have got it embedded. It can be used in very different ways. It's a tool at the end of the day, but it's a consistent tool. It's something that's the same across all areas of the system. And I think that will progress as time goes on, that you can then use risk scores and presenting need to really actually give much more appropriate care as to whether something could go, is it appropriate for a pharmacy? Is it appropriate for a nurse prescriber? Is it appropriate for a paramedic? Or does it need to be a geriatrician? And you can wrap services around the needs of the patient as well as their risk stratification.
So do you think this way of looking at data in particular, that's going to be pretty key, isn't it, to helping to develop neighbourhood working? That's kind of what the government really wants, isn't it?
So Frimley and other areas of the country are very far ahead in some of the breaking down of health data and bringing in some of the socioeconomic data. The socioeconomic data is the publicly available census data. I think what will need to change in the future is actually, when we look at federative data platforms, it will also need things like relevant and up-to-date financial data. So other socioeconomic data, have people moved, have houses changed? It'll need DWP involved, it'll need the DVLA involved, any sort of government organization that has data pools. There will need to be some sort of interoperability of linking the two so that you can actually combine social care and healthcare properly.
For it to be useful and practical, do you think it's going to have to be the same across a footprint? Or, there's obviously going to be certain elements that GP practices will buy themselves for their own practice, but do you think more of the buying of this kind of new tech will be at PCN level and above, so it's kind of consistent across an area?
So I think it'll always be mixed. Again, when we're talking about processes, the processes differ so much in every ICB, within every practice, within every PCN. And I think you'll need to keep a certain level of autonomy that we currently have in primary care so that we can be reactive very quickly and we can pivot very fast and we can take on new challenges. But equally, you can't expect a big complex system to change at the same speed. So I think there'll be some things that need to be a national level, some things will need to be a local level, some things will be a trust, but then it'll go right down to this works for our practice. This is what we'd like to do, because everything else isn't uniform. Our estates aren't uniform. Our skill mix isn't uniform. Our patient demographics are not uniform. So one size will never fit all.
I've been speaking to a few practice managers recently, and obviously one of the big problems now is that now you've got access to all this new tech. Everyone's got digital voice systems, they've all got online consultations, then there's all the other masses of information in the clinical systems. So practices and PCNs are basically awash with data. There's so much information, almost too much to know what to do with. Where should practices start? How can they make best use of the information that they've got?
So this is a great question. Somebody said to me, an anecdote is something you've lived, but the data can back up your anecdote and tell a true story. So if you're looking at data that you've already gathered, you can say that it's been, we've had hard work, we've had an increase in this, and you can look back at your data and it can confirm what it is that you're feeling. So you've actually got some numbers to go with it. You can also use it for forecasting and predicting the future. So as AI sort of sits on top, you can actually start doing control groups and bits and pieces. But these things are huge. I mean, if you're looking at that, most people would run away terrified and go, I'm not a data analyst. I don't want anything to do with it. So I think it's keeping it simple. We've got a really good population health platform that was developed by Frimley. And when I first got access to that, I think I lost 2 days of my life because I just kept going down different rabbit holes and going, that's interesting. Oh, look at that. Oh, that's cool. What can I do with that? I had so many ideas. I was like, I'm going to change the world. And well, actually, I can't. But what I can do is I can tweak and I can have a look to see, did it have an impact? Has it changed anything? As sort of the technology changes, what you'll be able to do is you'll be able to predict, well, if I make that tweak now, what will that look like in 1 year, 5 years, 10 years? And it will be across a system. So we'll have to have our system thinkers that are looking at it as the big picture. They're looking at the macro level. We'll have practice managers that look at a micro level, that look at what's going on in their practice. Then we've got our PCNs that look at what's going on in our town, our area, our locality, and look at the relevant that is data. Compare yourself to somebody that is comparable. There is very little point in comparing yourself to a borough in southwest London if we're a small town in Hampshire. Make sure you're comparing apples with apples, or as close as you possibly can do. And then similarly with PCNs, make sure you're comparing yourself to other PCNs, similar PCNs, and try to use the data to get rid of sort of biases or rhetorics that have been historically around for a long time. If you start to get to know your data and you're looking at it regularly, you can sort of really push back when people say, well, oh yeah, but it's always been like that. And well, it was until 5 years ago, and then they've clearly made a change at this point, and now it's not like that. So let's not make that assumption anymore and move forwards and look at what you're trying to achieve. If you feel that there is a problem somewhere within your practice, your locality, your population, see if the data confirms that, and then look at that process and think, well, how can I change that? What can I do differently so that it doesn't feel this way in 3 months, 6 months, 12 months time?
That's all really good advice. The problem I think that lots of people have, though, is that having the time to do that, because like you say, some of that stuff is quite time consuming and can take up a lot of time.
So I don't think you'll ever have the time to do it, especially in primary care. Some months I would look at it a lot more than others. Sometimes I'm looking at it daily. So like QOF targets this time of year, I'm looking at daily. Population health, I'm looking at possibly less so. The bit I actually really struggle with is trying to find the time to evaluate it, or making the time or the diary to say, well, let's look at this in 3 months, 6 months, 12 months. Did it work? Because often in primary care, we're moving on to the next problem, the next challenge, the next thing that's exciting, or the next new shiny bit of tech. And we forget to look back and share the story of what did work and why it worked. But it's looking for the easy wins with a large impact, and then looking for longer term wins, but will take time. But it is tough.
We've talked a little bit as well about ambient scribes. It's likely that there will be a big push on this in the coming years. And it was mentioned in the medium-term planning framework for the NHS. So loads of practices already use this technology, but it seems like it's something that maybe most practices will be using, or maybe all practices in the next 3 to 5 years. What's your view on those tools? How are they helping practices? Are they helping practices?
Yes. Yeah, no, they're brilliant. And I think what's amazing is they really first started coming about in my world about 18 months ago. And I think I've tried 9 different ones just to see what they were like. There are 2 that are excellent. And with the 10-year plan, and generally they're being pushed as being a time saver, to have proper conversations. For some people, they will be a time saver. We've got a generation of clinicians, anybody that's qualified more than sort of in the last 15 years can type fairly quickly anyway. they've grown up with MSN Messenger and texting and things like that. They're very quick with their fingers. So it's not, I don't think the time saving bit will be quite as important going forwards as the quality improvement. So when I look, I can tell who's using ambient scribe in my practice for taking notes because the details are so vast. It's really holistic care. It's well structured. It's well thought out. It's a true reflection of what's gone on in that consultation. And so I think in the same way that the call recording became mandated in practices, I think ambient scribes will almost be like your digital chaperone as a way of saying this is what happened in that moment. And I think it'll be a way of protecting clinicians and patients can then go back and again check on their online access to see what really did happen. What was it they said about that? Can I just go back? 'Cause they're listening, but if you in a 10-minute consultation, there's a lot of information to take in from a GP. And then they'll get quizzed on it, possibly by a loved one, a relative. Did they ask you this? What did you say about this? How was this? And actually, it will give them the confidence to say, no, this is what I discussed. This is what happened. This is what the plan is going forwards. It's all very clearly documented. That's where we'll see a really big difference going forwards and passing that information on and coding the information as well as the devices become more complex and you actually get more relevant medical codes coming out of them. It'll be really useful.
Obviously, you're really into all this tech. You've thrown yourself into it and you know a lot about it. But there will be practices where they don't have someone who is as up to date on all of this stuff. What sort of rules and guidance do practices need to be aware of around this? Because you've got to do your due diligence before you start rolling this stuff out, haven't you?
Absolutely have. And something I've spoken to quite a few suppliers about is that's something where there is a gap in education at the moment and it's a forever changing landscape. And some of the suppliers, I think Exxon and Accurex have done training courses on implementing AI and digital solutions. There's more coming, I think, from the national framework. Most ICBs have peer ambassadors. They've had a lot of education on this. I'm one myself. It's a really good program. It's a mixture of GPs and practice managers, but we've had some talks from some really good AI companies and what they're doing and what it means, also from the safety element in NHS Digital. So reach out, ask your ICB for who your nearest peer ambassador is, try and get them involved, ask them some questions. There's also really supportive groups. There's a great Facebook group for practice managers where you can discuss different things, ask questions. And I think most of the good companies will provide you with that paperwork, that reassurance. They'll go through it with you now. If you get a company coming forwards that doesn't have any of that information, the chances are they've not done it yet. They're too new to the market. So it's about choosing your risk. I mean, they might have the best product in the world, but if it's not been tested, do you want to be their test site? And most people won't. I don't mind. I'll take that risk. It's a big sort of time commitment, but equally you get to then shape what's coming in to work. But there are plenty now where they will give you all the DPIAs. They'll go through the risk assessments with you, tell you what you need to do, and they'll spoon feed it. So it's not quite so scary.
You've worked with lots of these tech companies to help develop some of these products, like you said there. Is it really important for people to look for products where there has been some involvement of practice managers, GPs in their development? Do you think that's kind of important?
I don't think any of these products would exist without some people giving up their time. And I think what I find really important is I never take payment. I always just be like, I'm interested. I want to be able to, I want to change the outlook and the horizon. And tech companies can't do it on their own. I can't build a piece of tech. So we've got to work together. You've got to talk to one another. They need to understand what's going on, the problem. And the best ones have people come into practices. They come and sit with you. They come and have those genuine human connections. And they keep making different iterations of their products and keep changing things and have a very public roadmap as to what they're doing.
The last thing I really wanted to talk to you about is obviously the 10-year plan has some really ambitious goals around the use of AI and new tech in the NHS. What are your thoughts about some of the objectives in that plan? Do you think they're achievable?
Yeah, absolutely. It shouldn't take 10 years. I think there would be some difficulties going forwards. One of the frustrations that we have at the moment, there's a lot of red tape to get through. I recently was speaking to a pediatric oncologist that isn't allowed to use ChatGPT, but is allowed to inject babies with radioactive chemicals. And he's like, how can I be trusted to do one and not the other? And I think there needs to be some trust in the people using the product. We do some very interesting and innovative things within the UK and the NHS when it comes to healthcare. And I think most people they're not gung-ho. They're not using other areas of healthcare and health tech to do really sort of rogue ideas. So we should treat tech in the same way. They go, well, let's give you the tools, see what you can create with it and come up with the user cases. And I think the other thing is that it's such a big market, and it tends to be that if something works within the UK market, it will then get adopted elsewhere in the world. So there is a huge focus on what we do with digital and tech in the UK. and there are some really great things coming about with AI. I think we need to be mindful that AI is not a silver bullet. And as I mentioned earlier, it's not a solution, it's another tool. And we need to use it appropriately and safely to do so. But safely does not mean not letting people use it at all, letting people use it within their remit, within their scope of expertise. And to manage that risk as well, I think is important. There's a lot of good things that it can do. I think we're in a bit of tech debt across the country. You look at the devices that we're using compared to, say, areas in the private sector. I get there is a big cost with IT hardware, but if your hardware doesn't match the software and the thing you're trying to do, that will just slow you down even further.
Is there anything about, the developments of tech going forward that you think are the most exciting things?
So I think the use of AI and the fact that I think it's mentioned about 180 times across the document, and because it's not a prescriptive plan, it's open to a lot of interpretation. I think that's really exciting because actually that will allow for transformation and innovation. And we can't continue doing things in the status quo that we're currently doing. So the more we can innovate, the more we can transform, the better it is. So that area really excited me. And I think looking at the left shift and population health is exciting. I think we're seeing it with the younger generations that are more aware of their health needs. We've got a lot more wearables, digital tech in our own personal lives that allows us to take ownership of what's going on. And I think there will be a big shift into people looking after themselves a lot more. That's key to the population.
AI is going to have such a big impact across the whole of society, not just in the NHS, that it's kind of inevitably going to make a massive difference on all sorts of levels, and probably ways we don't actually completely understand now in the next sort of 5 to 10 years.
Well, at the moment, it's as much as our imagination can allow, and that's quite interesting. So it probably will be able to do it, or somebody will be able to create an AI agent to do that for you. But your imagination is what's come up with it first.
That's been brilliant, Patrick. It's been great to talk to you today. Thank you for coming on the podcast.
It's been an absolute pleasure, Emma. Thank you so much for your time and the invite to do so.
Well, that's it for this week. Thanks again to Patrick, and thank you for listening. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.